These lectures will cover development and developmental problems in children. We'll start with some growth parameters. The average head circumference at birth is 35 centimeters. The initial growth rate is 2 centimeters per month for the first 3 months. This slows down after 3 months to 1 centimeter per month until the first 6 months, and then this slows again until 1 year. The head is growing at half a centimeter per month. The average birth weight is 3.5 kilograms. This will double by 4 to 6 months and triple by 1 year. The average birth length is 51 centimeters, and babies will reach half of their adult height by age 2 years. Next, we'll review some of the gross motor milestones to expect in the first year of life. The primitive reflexes disappear by 3 to 9 months, so kind of a broad window, but they're gone by 9 months. The postural reactions start between 3 and 10 months, so they start transitioning from primitive reflexes to postural reactions. Newborns will be able to turn their head to the side. They'll show still evidence of a head lag, and then they'll have the reflexes of Moro, step, and grasp reflexes. At 2 months, babies won't have the head lag anymore. They'll keep their head in line. They can lift their head up to 45 degrees when they're prone, and they can follow objects past midline. At 4 months, they'll be able to lift their head to 90 and put their chest up on their arms, and they can start rolling from prone to supine. At 6 months, they can roll from prone to supine, and they can lift up onto their hands from their chest. They can also sit with support at 6 months. At 9 months old, babies can crawl and stand, and at 1 year, they start taking their first steps and standing without help. Next, we'll review the fine motor skills in this time period up to 1 year. At 3 months, babies will just be swiping their hands. At 4 months, they'll start bringing their hands to midline. This is around the time that babies start teething in anticipation of solid food initiation, so they start putting their hands into their mouths. At 6 months, they'll be able to transfer objects back and forth, and at 6 months, they'll show the raking. At 9 months, they'll show an early immature pincer grasp and start feeding themselves with their fingers. And at 12 months, they'll have the mature pincer and be able to release objects from their grasp. Next, we'll review the language and speech milestones for the first year. At 2 months, babies will start cooing and smiling. At 4 months, laughing. 6 months, babbling. At 9 months, they'll have a mature babble and start responding to their own name. At 1 year, they'll start assigning mama and dada to specific people. They'll have 1 to 2 words, and they'll be able to understand commands. Next, we'll review the social milestones in the first year. At 2 months, infants will show social smile. At 4 months, they'll start laughing. At 6 months, they'll show stranger anxiety and that they understand object permanence. At 9 months, they'll be waving and lifting their arms to be picked up. And at 12 months, they can play simple games like pat a cake. After the first year of life, there's some commonly tested early childhood milestones as well. At 15 months, a child will be able to walk well and walk backwards. They can also crawl up the stairs at 15 months. An 18-month-old will be running, but it'll be clumsy. An 18-month-old can go up the stairs only with 2 feet per step and can throw a ball. A 2-year-old runs well with a wide gait. A 2-year-old can go up and down the stairs, kick a ball, jump, and stand on 1 foot briefly. A 3-year-old walks on their tiptoes if they want. They can alternate feet up the stairs. They can stand on 1 foot for 1 to 2 seconds, and they can hop, broad jump, and tricycle. A 4-year-old can hop 5 times, stand on 1 foot for 3 to 5 seconds. A 5-year-old can skip and can go up and down the stairs with alternating feet. A 15-month-old can stack 2 cubes and scribble. They should have between 4 to 6 words and point to ask for things. They should be able to follow 1-step commands without gesturing and should know at least 1 body part. An 18-month-old can stack 4 cubes and they should know closer to 20 words. They also start pointing to show people things. An 18-month-old should know at least 5 body parts. 2-year-olds can stack 6 cubes and draw strokes. They should have more than 50 words and start putting words into 2-word sentences at 2 years, and they should be able to do things like pointing at objects in a book to other people. 2-year-olds should also be able to follow 2-step commands. At 30 months, they'll be able to stack 8 cubes. At 3 years, they should be able to build cubes into a bridge and draw a circle at 3 years. A 4-year-old stacks blocks into a gate and can draw a cross and a square at 4 years old. A 5-year-old can draw a triangle. A 6-year-old can draw a diamond. And a 7-year-old can make the block into stairs. To try and avoid developmental delays, we're performing surveillance at each well visit. We also perform formal screening at 9 months, 18 months, and between 24 and 30 months. Language delays are most predictive of other delays, and it's better to think about a patient's current level, not the milestone recall, to determine their developmental status. The Denver test and the Bailey test are good validated screening tools. The Bailey is considered the best. And then another nuance that you might be tested on is that the developmental quotient is not correlated with IQ. Next, we'll review some warning signs when you'd be concerned if a child isn't reaching a certain developmental milestone. If a child doesn't respond to their name, we'd be concerned at 9 months. If a child is not babbling, we'd be concerned at 1 year. If a child doesn't respond to no or bye-bye at 15 months, this would be a reason for concern. If a child doesn't have any words except for mama and dada, or if they're not pointing, we'd be concerned at 18 months. If a child doesn't have 2-word phrases or 2-syllable words, or if they're not understanding commands, we'd be concerned for a 2-year-old. If a child isn't intelligible to their family and is still showing echolalia, we'd be concerned for a 3-year-old. If a child is not intelligible to strangers, we'd be concerned at 4 years old. A child who's stuttering, we might intervene by age 5. If a child has uncommon speech errors, then we'd be concerned at a 6-year-old time frame. Some common speech errors that we tolerate in 6-year-olds are sounds like ch, sh, the z, the j, and th, or lisping. An 8-year-old should not have any speech errors. Some specific nuances regarding language delay. The diagnosis of specific language impairment would imply that a patient has normal hearing and IQ, but just has expressive speech delay. This is often familial and is associated with reading and behavioral problems. Stuttering can be considered normal until age 5. We think about speech therapy, SSRIs, and risperidone if we're going to intervene. We might intervene if the stuttering is distressing to a child, if they've had it for more than 6 months, or if it started after age 5. Landau-Kleffner syndrome, also called acquired epileptic aphasia. Patients will have sudden language deterioration between 3 to 7 years, and they also have seizures. We treat these patients with IVIG, steroids, antiepileptics, and sometimes they need surgery. Next, we'll go over some nuances regarding sleep. In REM sleep, this is where dreams occur. A patient would have a low threshold to stimuli, and they would be considered physiologically active but paralyzed with inactive muscles. Parasomnias typically occur in non-REM sleep, which is also called N1 to N3 delta sleep. At 2 months, babies will start to have a day and night differentiation, but before that, they're just guided by their feeding schedules. Infants have a greater proportion of REM sleep than older children. For sleep requirements, newborns require 16 hours. At 2 months old, this decreases to 15 hours. At 4 months old, 14 hours. At 12 months old, they need 13 hours of sleep. A 4-year-old needs 10 to 12 hours, and a teenager needs 8 to 9 hours. When children have sleep onset association disorders, toddlers will manifest with bedtime refusal, and older children and adolescents will describe insomnia. When a patient has night terrors, these typically occur within 1 to 2 hours of sleep onset with partial awakenings. We can help patients with night terrors by scheduling awakenings to try and break this cycle. Some patients require TCAs and benzodiazepines. Periodic limb movement disorder and restless leg syndrome can also affect children. We treat these with medications as well. Rhythmic movement disorders look like head banging and rolling around in toddlers during their transition to sleep. Sleep startles or hypnagogic jerks occur during a sleep transition and are benign. Nocturnal seizures occur throughout the night or with arousal. And then with narcolepsy, patients will describe sleep paralysis, hallucinations. We would diagnose these patients with a sleep study and sleep latencies test and treat them with stimulants or modafinil. You're examining an infant for a routine well visit. At what age will you first be concerned about the need for further developmental screening if the infant is not rolling over? 2 months, 4 months, 6 months, 8 months, or 10 months? The correct answer is 6 months. A typical infant is laughing aloud and rolling over, but has not begun to babble or sit with support. What is the likely age of this infant? 2 months, 3 months, 4 months, 6 months, or 8 months? This infant should be 4 months old, laughing and able to roll over, but not yet babbling or sitting with support. A child can go up the stairs alternating feet, but needs to use 2 feet per step to go downstairs. What is the child's likely age? 18 months, 24 months, 36 months, or 48 months? The correct answer is 36 months. A 3-year-old can go up the stairs alternating feet, but has to go 2 feet per step to go downstairs. A child can stack 8 cubes but cannot make a 3-cube bridge. What is your best estimate of their age? 15 months, 18 months, 24 months, 30 months, 36 months? The correct answer is 30 months. The second half will review developmental and behavioral problems. You're a general pediatrician practicing primary care with a large patient panel that's representative of your socioeconomically diverse community. Approximately what percentage of patients on your panel should you expect will at some point be diagnosed with a developmental disability? 5%, 15%, 25%, 40%, or 50%? The correct answer is 15%. To review, we perform surveillance at each well child visit for developmental screening, and we use validated tools at 9, 18, and 24 to 30 months. We use the MCHAT at 18 months and at 24 to 30 months. We define a delay if we're assessing missed milestones that add up to 1.5 to 2 standard deviations or more below the average for age. A patient with a global delay means that they have more than one domain delayed. These patients will have intellectual and adaptive impairments. Instead of the diagnosis of global delay, we use the diagnosis of intellectual disability if a patient is older than 5. There's a 5 to 10% prevalence of speech delay, and it's more common in boys. Some common speech disorder diagnoses are stuttering and the phonological speech disorders. Language disorders can be receptive, expressive, or mixed. Patients are commonly treated with speech therapy, and some parents need training as well. The IDEA Act allows for early intervention until age 3 and special education up to age 18. A 4-year-old boy comes for a well child check. His mother reports that at age 2, he was diagnosed with global developmental delay because he had significant delay in speech and language, problems with fine motor tasks, and difficulties with problem solving. Now he's in preschool and continues to have problems expressing his needs, understanding rules, and learning new things. Which of the following is the most important next step for this family? Referral for a genetics consultation, referral to a pediatric neurologist, referral for special education assessment and an IEP, or reassurance? The correct answer is referral for special education assessment and an IEP. We use IQ to define if a patient has an intellectual disability, if IQ is less than 70, or if the cognition is 2 or more standard deviations below the mean, and there's functional impairment, then we can diagnose an intellectual disability. This also should be present between 5 to 18 years, otherwise we use the term global delay. Intellectual disability is associated with Fragile X syndrome, trisomy 21, fetal alcohol syndrome, the Torches infections, HIE and TBIs, and with lead and mercury toxicity. We should make sure that we can't find any evidence of an organic problem like a hearing or vision problem, and we should get a lead level. Patients with intellectual disabilities can benefit from the IDEA Act services and regional center. You're seeing a 3-year-old boy who had a diagnosis of developmental delay at 18 months and has been receiving early intervention. His growth has been at the 50th percentile for height and weight, and his head circumference was at the 99th percentile. You note that he says only "ma," does not look at you, and seems fixated on his toy. What should you do next? Administer the MCHAT, refer to a trained provider for an autism evaluation, refer to a speech therapist, order a brain MRI, or order an EEG. The correct answer is to refer to a trained provider for an autism evaluation. Patients with autism spectrum disorder will show social emotional deficits, problems with nonverbal communication, and problems with relationships. They might show stereotypical or repetitive movements, inflexibility with changes in routines, restricted interests, and hyperactivity to any sensory input. To review, we performed MCHAT screening at 18 months and at between 24 to 30 months. The gold standard is the ADI diagnostic test and the ADOS test. If you confirm a diagnosis of autism spectrum disorder, you should perform a chromosomal microarray because of the association with Fragile X syndrome. These patients don't routinely need EEGs or MRIs though. You're seeing a 4-year-old male in your clinic. He was recently diagnosed with autism. He's receiving ABA therapy and speech therapy in school. He has shown some progress, but his mother would like to know if he needs any neurological or medical tests. What is the next best step? Check a CMP, refer for brain MRI, refer to genetics, or EEG. The correct answer is to refer to genetics. You're seeing a 12-year-old girl because her parents are concerned about her school performance and think she may need referral to a psychologist. Her teachers report that she zones out in class, forgets to turn in assignments, and seems to be easily distracted. Her parents note similar behaviors at home and have trouble getting her to complete her homework. She is otherwise well and has a normal exam. She reports a normal mood and denies any substance use. What is the next best step? ADHD medication, EKG, EEG, or ADHD measurement tool? The correct answer is ADHD measurement tool. ADHD can be either inattentive, hyperactive, or a mixed type. To make your diagnosis, you need 6 symptoms from each subtype, and they should last at least 6 months. The symptoms should be present before age 12 and in at least 2 different environments. We treat ADHD with methylphenidate, atomoxetine, bupropion, clonidine, and guanfacine. Most of the ADHD medications cause tachycardia, hypertension, insomnia, and anorexia, but guanfacine has a sedative effect. With learning disabilities, we have specificity for reading, writing, or math disorders. With the DSM and IDEA definitions, we would try a period of intervention and then define a learning difficulty that's refractory to that to define the diagnosis. The IEP specifies supports and modifications for each student with learning disabilities. If a child has a diagnosis of ODD or oppositional defiant disorder, These patients will show a persistent pattern of outbursts, arguing, and disobedience to authority figures, but not necessarily a sibling. They'll show these symptoms daily and weekly for 6 months or more. About 1 in 3 of patients with ODD will progress to a conduct disorder later. Conduct disorder is marked by violating others' rights, a lack of guilt, cruelty to animals, destruction, and bullying. Conduct disorder patients have a high risk for progression to antisocial personality disorder. We treat kids with ODD with therapy, parenting management, and emotional skills training. For anxiety, separation anxiety is normal in 9-month-olds and in 1 to 2-year-olds, but they should still be able to separate in familiar environments. If someone's diagnosed with separation anxiety disorder, these children should be older than 6 and should have symptoms for at least a month. School refusal is a common symptom for all anxiety disorders, especially separation anxiety disorder. With generalized anxiety disorder, patients will describe worrying about different things for at least 6 months. Patients with panic disorders will have episodes of chest pain and tachycardia. We manage anxiety with CBT, desensitization, SSRIs, and therapy. With OCD, anxiety turns into compulsive behaviors as an attempt to manage it. It's also associated with tic disorders. We treat OCD with CBT, habit reversal therapy, SSRIs, and TCAs. A commonly tested nuance for trauma and stress-related disorders is the difference between acute stress disorder and PTSD. If a patient has acute stress disorder, you're seeing them less than 1 month after the event. If a patient has PTSD, you're seeing them more than a month after the event, and their symptoms should have been persistent for at least 2 weeks. Major depressive disorder is diagnosed if a patient has the SIGI-CAP symptoms for at least 2 weeks. Bipolar type 1 features mania and depressive episodes. Bipolar type 2 features hypomania and depressive episodes. Hypomania contrasts from mania in that hypomania is marked by just described as silliness, increased activity, and a decreased need for sleep. So sort of a milder version of the manic symptoms that we see with bipolar type 1. Cyclothymic disorder associates hypomanic symptoms and depressive symptoms, but it doesn't meet the full bipolar criteria. Patients with cyclothymic disorder should only be diagnosed if they've had the symptoms for at least a year. You're seeing a 6-year-old girl in clinic because for the past 3 nights she has wet the bed. She was toilet trained at age 2.5 and has not had nighttime or daytime enuresis or encopresis since that time. She's been afebrile, but her teachers and parents note that she seems to be using the bathroom more frequently than usual. She denies vomiting, constipation, and diarrhea, but is mildly distressed and embarrassed about these new nighttime accidents. What is the next best step? Make a referral to child psychiatry, make a child abuse report, tell the parents to buy a mattress alarm and limit fluids before bed, get a urinalysis. The correct answer is to obtain a urinalysis. We would diagnose enuresis and delayed toilet training in a child who's had repeated accidents and they're at least 5 years old. Primary enuresis would be in a patient who's never had a UTI and is not toilet trained. Secondary enuresis would be diagnosed if a patient had a dry period of at least 6 months and then enuresis developed. So you'd be concerned more for organic etiologies like UTI and diabetes insipidus, and you would also scrutinize potential psychosocial stressors. We treat enuresis with scheduled voiding, urine alarms, and DDAVP. Provisional tic disorder is given to patients who have symptoms for less than a year, and the symptoms should have started before age 18. Chronic motor and vocal tics diagnosis would occur if a patient had motor or vocal tics for at least a year and if their symptoms started before they were 18 years old. A patient has Tourette syndrome if they have more than one motor tic and at least one vocal tic. They should have had these symptoms for more than a year and an onset before 18 years. And patients with Tourette syndrome can describe that their symptoms wax and wane. We use some validated scales to grade tic control. Sometimes the board will ask you if reassurance is appropriate, and these are some possibly normal behaviors. We would consider thumb sucking to be abnormal after age 4 to 5. It's associated with poor dentition, pica, and accidental ingestions. Colic peaks at 6 to 8 weeks and is defined as patients crying at least 2 hours daily. Breath holding can occur in patients up to age 3. If the breath holding spells are prolonged after age 3 or they don't seem to be in response to an emotional change, then you might consider an EEG. Tantrums and biting and hitting are abnormal if they're not improving with age. And then last, some tested points about suicidal behaviors. Suicide is the third leading cause of death for 10 to 19-year-olds. We see that in girls, contemplation and attempts are more common, but in boys, completion is more common. And that is the last slide for this lecture.